All right, everyone, we're going to go ahead and get started, and thank you for joining us today, third day of the conference. And I think just from my observations of past 3 days, it's safe to say that there's an incredible amount of innovation taking place. And some of the sessions that I attended, it's also been reaffirmed that no technology operates in isolation. And the degree of interconnectivity will only grow. And another observation is that while there is a lot of amazing technology and we're really only on the cusp, there's also going to be a lot of challenges with implementation. And one of the discussions that we would like to have today is not just the challenges that a large hospital may have, but what are some of the challenges that a small or mid-sized healthcare provider may have? And not only in selecting and screening the technology, but in the implementation, the ongoing management, and even optimizing the technology. So that seems to be one of the discussions that there could be a little bit more focus on, and that's what we'd like to talk about today. So with that, let's go ahead and introduce our panelists, and then we'll go ahead and share a few data points, and we'll tee up a few questions. But certainly, I view this as somewhat informal, so if you have questions during the session, feel free to get up if you need a clarification or whatnot. Just go ahead and jump right in. So with that, why don't we start with Kevin? Why don't you introduce yourself to the audience?
My name is Kevin McDonald. I'm the Executive Vice President of Alvaca Networks. I'm also the Chief Advisor and Chairman of the Orange County Sheriff's Department and Coroner's Office Technology Advisory Council, member of the High Tech Crimes Consortium, and lead technology trainer for Safe House Anti-Terrorism and Force Protection, member of the LA Electronic Crimes Task Force, and a certified HIPAA privacy and security expert.
My name is Jeff Watts. I'm an IT service provider with a specialty in healthcare IT implementation and consulting out of the Philadelphia area.
And my name is Tim Herbert, and I am the Vice President of Research for CompTIA. And CompTIA is a trade association. So I'm sure everyone has heard of the American Medical Association. CompTIA is a trade association for technology companies, and we spend a lot of time thinking about different ways to improve the way that we are offering services, certainly following trends, and really we're here today to share some of the experiences that we have on the technology service provider end and help connect that to how small and mid-sized healthcare providers manage their technology and some of the other issues that we talked about. So with that, I'm also going to share a few data points where appropriate. And one of the functions of our trade association, in addition to some of the education and networking and policy work, is research. We do quite a bit of research, and we typically try to capture a variety of perspectives. So we want to certainly capture the perspective of some of those providing and implementing and managing the technology, but also the users. So some of the data today is primarily among physicians in small and mid-sized healthcare practices, but also office administrators or nurse practitioners, some of the others that are actually using the technology. And if you recall, certainly the largest base of healthcare provider is the small practice. And while that is changing, they still represent a fairly significant share of our healthcare provider ecosystem. So a lot of these decisions are made within practices that don't necessarily have a CIO, they don't have an IT department. Many times they are the chief technologist, and that can present some issues. So just to tee up and to set the stage a little bit, and there's a lot of different strategic priorities among healthcare providers, and we had a very long list of different items. And some of the ones that bubble to the top, you will notice, and again, these really shouldn't come to a surprise to anyone. It's more of a confirmation of what I think we all observe and what we know. But I think it does provide a good segue into, what is that initial thought process like? It's usually not, I need to buy technology. It's usually, I need to solve a certain problem. And what is the technology? What is that end to the means? So with that in mind, why don't we go ahead and start with Jeff. And maybe you could just describe a little bit about what you're seeing with some of your customers and some of the healthcare practices that you're now working with in terms of when you have that initial engagement. What are some of the big picture issues that they're trying to solve? And before we get into the actual technology and the implementation, what are the big questions that they have and what do they want to accomplish?
Sure. So I'm working with providers from 1 to 10 on average, 1 to 10 physicians in the office, maybe multiple locations. And their primary concerns are definitely the cost. They think it's very costly to bring any consultant in to implement new software, and the time to do it. They're not sure how long it's going to take, if they're going to be not able to see patients, or what that all entails. They're definitely concerned about new rules and regulations by the government, and also complying with new HIPAA regulations. And a big thing that I see is that they think their office is already running to the maximum efficiency. And we find that once we start working with them, that they quickly understand that they're not running very efficient, and there's many problems in their workflow that may be costing them money. And the last thing is definitely that they may have an IT person, or maybe their son or daughter works on their computers, and they think that that's sufficient, and that one person can handle all of their IT needs, and they don't realize that there's a whole other sector in health IT that their IT person may not understand.
Kevin?
Yeah, can I ask the audience first, before we get any deeper, how many of you are actually physicians? And then how many of you are in IT? Okay, and then how many of you are administrative in nature? All right, perfect. We're seeing a variety of different things when it comes to technology. I mean, there's, of course, the desire to improve productivity. In the mobile health, we're seeing a lot of the coolness factor, I think, as much as anything else. We're also seeing the desire to reach out and save the trip to the doctors as much as we are to save money, provide convenience, extend healthcare out into the rural areas as much as anything else. In the larger enterprises, we really are seeing a consolidation in technology, trying to bring things in and simplify things as much as we are in trying to advance the technology itself. Really, there's too many things, and we're really seeing more to narrow it into one more centralized dashboard-like environment, I guess would be the way to put it. In the smaller practices, I think we're seeing the implementation of technology at its infancy. And so much of what we wanted to talk about today is how do you implement from the beginning. So that's why I ask how many of you are in IT, and maybe we can discuss at what level some of you are at, and find out how we can help you move to the next level.
Yeah, and I think that is also borne out in the data. And that is something that we track for a lot of different industry sectors. And it, again, is not necessarily something that is meant to be a surprise, but it's more of a confirmation that we do see the recognition that information technology is affecting more businesses on more levels than ever before, and that trend is only going to accelerate. And I think one of the areas that it's interesting to look at is, what are some of the immediate issues before we even can start talking about the next wave of technology? Jeff, where do you see some of your customers today in terms of either their infrastructure? You mentioned that some have the false impression that they are operating more efficiently than they truly are. From a technology perspective, where do you see some of your customers today? How would you assess when you go in to do an initial assessment?
Sure. Most of the computers are outdated. They might have a client-server network, but more often than not, they have a different billing system, an appointment system. They may not have an electronic health record system at all. So really the software is scattered around, in particular in the small offices. And they don't really see the need to upgrade into a system that does everything, maybe because they're getting by, and maybe their front office is doing most of the work, and really the physician doesn't see the pain points that the front office people do see, which could be very detrimental to the efficiency of all the employees. So there's definitely some software upgrades that primarily need to be addressed when we walk into a small provider.
And I think we're also facing a lot of bring your own disaster. A lot of the BYOD that's happening right now out of convenience is actually going to lead to, in my opinion, a lot of inconvenience and a lot of long-term problems if we don't be strategic and think about how this is being done. Between the FDA and the HIPAA compliance issues that are coming in the long term, if people continue to bring their own devices into regulated environments without long-term consideration, I think we will see very significant implications when it comes to fines and more pushback from organizations like the Office of Civil Rights in the long term.
And certainly we must acknowledge that there are situations where the technology is just not ready for prime time, or there's a mismatch between needs and expectations. Jeff, are you finding that in situations where potentially there's dissatisfaction? And what do you see as some of the sources of dissatisfaction with IT today?
Sure. So if as IT service providers, when you go to demo the software, you're going to hear a lot of great things that the software can do from the software vendor, and then you quickly find out when you go to implement that it really doesn't have those features. And that's a huge obstacle to overcome as an IT vendor, because you promise something to a physician or to the staff, and then you have to create workarounds to give them the features that they really want. And to walk into an office that already has technology in place, you're finding that they can't do something because of software limitations. And as a consultant, it's your job to find ways around those limitations so the productivity of the office is not slowed down. So that's a frequent problem where the software has limitations and you're forced to create your own workaround because the software vendor doesn't have enough support to really resolve the issue.
And I think another contributing factor that we hear over and over again, that a lot of technologies is simply too complex, and the user interface is maybe not optimized, or it's not as easy to use as Facebook. But there are trade-offs. And Kevin, when we were discussing earlier, some of the trade-offs between maximizing the user interface versus security, compliance, and some of the back-end requirements that maybe are not as fun to talk about, but can be problematic. Any thoughts on where or how we go about thinking about it?
Well, I think the truth comes down to this. What is easy or convenient or what you can do doesn't necessarily equate to what you should do. So I think part of the problem is that healthcare is one of the greatest places for innovation. It is one of the best places where convenience, speed, and sharing of information has value. But the federal government and state governments have decided that the easy sharing of information and the ready sharing of information is conflicted with the rights of the patient, privacy. So while I agree that these are all wonderful concepts of sharing quickly and easily and having very fast sharing of information is great for doctors and great for innovation and patient care, it completely conflicts with the way the federal law is written. It's awesome when it comes to the end user patient tools. A lot of these apps that we're seeing right now, as long as it's the end user initiating the use of that app, you're okay. So if you are not implementing these tools, you as an organization are fine. The second you begin to start to implement these tools, this is where we get into this conversation about how are you going to implement them, because you do then need to consider things like there's a 3-year back requirement on disclosure. If a patient says, who's looked at my record, you have to be able to reach back 3 years and say, who have you disclosed this medical information to? Well, many of the mobile health apps that have been produced outside of larger enterprises don't have these auditing capabilities. So as IT people, you need to be able to help with that function. Privacy encryption or data encryption is a fundamental function of data privacy. If the app doesn't provide that, then you have to question instituting that in your environment. So these are things that easy functionality may not be convenient for the end user, but they're required in your environment. So they conflict with each other. And unfortunately, until the regulatory environment changes, which I don't see it happening anytime soon, they are going to be a conflict.
And as I mentioned when I first opened, there are a lot of moving parts and a lot of variables to some of the discussions we're having today. And certainly, one of the ones that, and part of the reason we're having this panel today is the simple management of the IT function. And that's one of the biggest decisions that any business must face, whether it's a healthcare provider or not. And to what degree do they do everything in-house versus they outsource everything or something else on that continuum. And we found for the most part among the small and medium practices, while they're doing a fair amount themselves internally, they're also working with some type of outside IT service provider, IT solution provider. So just to set the stage for some of the discussions we'll have in a minute, I wanted to share this data with you. And we do find that a lot of it is project-based, meaning that they have an implementation or they need to integrate two pieces of software. Although the concept of managed services, certainly the concept of managed healthcare is well known at this event, but managed services, managed IT services, that's something in the IT sector that may not be quite as well known, but we do see that roughly 1 in 5 are using some type of model where they're essentially outsourcing a large portion of their IT in some way. And Jeff, since you are certainly an MSP, maybe you could just share a little bit about your model and what's a typical engagement like for one of your customers?
Sure. So the 1 in 5 number really has to come up. It's not enough providers utilizing a managed service provider. And the IT companies have to really get the health IT knowledge, the HIPAA knowledge. And basically how we work is we have a cost model that is affordable for any size physician, and it's basically based on how many seats they have, how many employees they have, and how complex their network is. So we can a price per employee that is manageable for them and is manageable for us. We'd rather have their network run smoothly all the time and have minimal on-site time and break-fix time and do all the work behind the scenes at a managed level. So we have tools running on all the workstations. We do periodic checks on their security and compliance, and we're doing proactive services, which all providers should take advantage of. It's more cost-effective in the long run, and it keeps their company running smoothly.
I'd like to ask, there's a lot of IT people in this room, so I'd like to ask, what are the challenges that you're having in implementing your mobile health technologies? Because what I see in the enterprises that I'm working with are, you've got a lot of BYOD coming in with lack of central deployment, central management. You've got a lot of people that want to use their devices that really you don't have any visibility into. You can't control where your content's going. Give us some idea of how we can help you deal with implementation. Is there anybody in the audience that have any questions for us? I've never seen a room full of IT that didn't have questions. That's amazing. Okay. Yep. The FDA's paper on that, there's a draft document that came out in 2011. They haven't released regulations yet. However, what they've basically said that if you're extending data from an FDA-regulated device, and even if it's a pass-through, that is considered an extension of a medical device, and it will ultimately be regulated. That is their statement at this point. If it is creating, if it's a new device that's doing what you're talking about, which is calculating or creating a diagnosis or taking information and providing a recommendation of any type, it will ultimately be a regulated device. So that's the the best way. There's actually a paper that was written by the FDA that gives you a pretty well described paragraph on what they will be regulating when they release final regulations. If you look up FDA regulated medical apps in Google, it will come back. It's a pretty easy search. So on the implementation side, the way I look at it is this. Medical or mobile apps are really not very different from any other device, with the exception that they have people's lives at the other end. So that makes them pretty different, right? You have reliability issues, you have security issues, and then, of course, you have regulatory compliance issues that you have to deal with. So, and the difference is security and reliability are part of that regulation environment. So when you're doing your implementation, you can't just turn it on and hope. You have to actually do some planning. So a lot of what we're here to talk about is, what does a small practice do if they have no technology at all? You want to be careful about just putting in a technology. We talked about this a little while ago prior to coming in here. You don't want to buy an application and then consider what is the impact on your internal systems. If you don't have a network, you have to consider your bandwidth implications. You have to consider, are you going to need to put in an infrastructure? Do you need switching in a firewall? Do you need to put in some sort of security infrastructure? Who's going to manage it and be responsible for it? Well, what are the implications? The other thing that I find as a consultant a lot when I go in and do independent reviews is risk management is being dropped at almost all levels. When you do a new deployment and you're doing mobile health, risk assessments have to be done every time you do an injection of a new technology. Every time. So you have to do an assessment. What is the risk when I do this new device? At what point? So the risk at the endpoint, the risk on the transmission, and the risk on the use, the storage of the data. You also have to have an emergency mode of operations plan. So as part of HIPAA. So if that device stops working, what's the emergency mode of operations plan? Is it vitally important to your practice? If it is, what are you going to do to replace its function when it stops working? So these are some of the things you need to consider when you're doing implementations.
Yeah, I mean, I think along those same lines, the whole buy, build, manage in-house, outsource. Jeff, when you get either the questions or potentially some of the perceptions of outsource versus buy versus build and so forth, how do you walk your customer through that? Like, how do you help them understand the variables and the trade-offs between the managed services model versus doing everything in-house or somewhere in between?
Sure. Well, the first thing that you have to break down is that they may think that the EHR vendor is going to provide all their support, and it's just simply not the case, as I'm sure you found out. So then once you're in the door and you have to decide or to get them to go with a managed service plan, you just really have to show them the value in that, whether it's keeping them on an hourly plan until they get comfortable with you, and then slowly moving them over to a managed service plan, or just showing them some examples, some testimonials from some of your other customers that are already on a managed service plan, and slowly ease them into it, because they may not understand what that means if they've never had that before.
And maybe you could also just mention, because I think it was an interesting analogy that you made earlier about the fact that a lot of managed services, there's a remote component to it, and it's almost analogous to telehealth or remote monitoring in the healthcare space. To what degree are you on site versus are you keeping an eye on the systems and managing the systems remotely?
Sure. So yeah, we're managing their systems remotely 99% of the time, sometimes 100% of the time, and that needs to be conveyed to the physician. When we first implement a project, we may be on site to get them and their staff familiar with the system, but once it's in place, we really remove ourselves from the situation and are able to manage them completely remotely.
One of the other things I think that's important to the point of remote support is considering how you're going to support the device once it gets out there. We find a lot of people are really good at buying devices and getting them deployed, but then tracking them is a real challenge. Where did it go? Who has it? What's on it? How do I get it back? What happens if it's lost? So when you're selecting your technologies, be sure that you're asking the right questions about how do you locate the device? Is it part of a central management system that would allow me to either wipe it or brick it, making it useless if it is lost at some point? Can I reset the password from remote, for example? How often do you get a phone call from a person who's lost their password and can't access the data? This isn't good in a clinical situation when a doctor can't get a hold of data that's on their device. So functional management of a device is really important if you're going to be deploying mobile health solutions. And this is, again, where the challenge of bring your own device comes in. We're seeing a lot of that where it's convenient to buy a little app. The other issue I want to really give people a kind of a heads up on BYOD, and many of you IT folks do recognize it already, but I do want to reinforce it, that we've seen many instances of malware being found in applications that have been purchased legitimately on websites like Android Store and the Apple Store and others that have been found to have been porting data to foreign countries and other locations that shouldn't have been. So if you're going to trust applications from unknown entities or non-responsible organizations, I would suggest you be very careful about allowing those applications to connect to your back-end databases.
And as an IT provider, I would definitely make sure that your internal processes are down, and that you have a way to manage these remote devices. You have an RMN tool that's able to track assets, laptops, smartphones, computers, servers, everything. It's your responsibility to be able to show your client that you actually are managing their network, and at any given point you could run a report and show them what they have and how it's being used.
In fact, your HIPAA requirement says that you have to have a media management plan as part of the HIPAA regulation.
Following up on that point, so what was the path, or what is the route to the point of seeing a interesting application to evaluating it to implementing it? What recommendations do you have to ensure that it is, one, compliant, but also, two, is going to benefit the practice in some way?
Sure. So we always start with talking to the physician or a key employee and asking them what their ideal situation is. Think of the best thing that you can imagine, and then we'll go and try to find an app or a service that can provide that or get close to it, and then work back from there. Kevin may take the security and look at that right away. We'll look at a variety of apps first and see what would actually work, and then we'll demo it in our internal side. We're not going to demo it on their network. They just simply don't have the time for that. Then once we come up with some apps, we'll give them some options and show them the features that they do have with their ideal plan and what they're giving up, and kind of come up with a comparison matrix on what we found.
Yeah, I like to look at first what they're trying to do with it. What's the end game? What are you trying to do? What's the productivity gain? What's the patient outcome? What are you trying to get to? And then we get to the point of, I look at security, because frankly, if the app can't meet the security requirements, then there's not a whole lot of point of spending a whole lot of time digging into it. But often security layers can be wrapped around applications. One of the things that's really important to think about in implementing, I heard a comment about this about 2 days ago in one of the other presentations that was a little offhanded, so I wanted to reinforce it for anybody that didn't hear it. One application by itself may be secure, and another application by itself may be secure, but tied together they may not be. So one of the things that's really important when you're doing implementations is to do test beds. Put together your test environments and tie the applications together and make sure that you retest as an integrated application, and then find out if they're still secure, because often hackers will use the combined functionality of two or more applications to identify weaknesses. And they may be standalone very secure, but together they may not. And it is important to identify that one without the other is better than two together.
And one of the other data points that came out in the research, we found that roughly 1 in 3 healthcare providers, they report getting requests from patients for app recommendations. So the patient is looking for a fitness app or an app to track some type of medical condition. And you can imagine some of the legal complexities around making that type of recommendation. And certainly we discussed this earlier, and what are your thoughts on where this may be headed?
I'm going to defer to Kevin as far as security, but as a patient, I would want my physician to have the ability to recommend some sort of app that I can use to manage my personal health care. And I think every patient wants that flexibility for the physician to actually communicate about that, but they do have more regulations and laws that they have to follow, and I'll let Kevin expand on that.
Yeah, I think this really comes down to either PartnerNet, so you would either have to create a PartnerNet of trusted apps or don't make recommendations. That's kind of the person who's raised by 2 attorneys that says if you make a recommendation and something goes wrong, of course you've got an issue. So, and the other problem is if they go choose their own app, then what's the problem? But I'm of the opinion that you may want to have some sort of a process of vetting out partner applications that you as an organization feel comfortable with. Your legal counsel says, yeah, okay, and you get together your documentation between the 2 organizations. Just like you would implement any other application, you vet it out carefully, make sure it works the way you think it is, and then make recommendations only for those applications that you're comfortable with.
Yeah, this just, I think, reaffirms some of the risks that Kevin mentioned, and particularly the one regarding malware. A report came out that the increase in mobile malware was roughly 155% in 2011, and we can only expect that to further increase. And it's simply the law of economics. The number of devices as they grow, as these devices are housing more sensitive information, whether it's credit card information or healthcare information, we can only expect that trend to increase. Any other questions, or anyone have an experience to share regarding, say, a mobile malware that they may have picked up, or anything else that you want to tee up on that topic?
So on the implementation side, I think something that's also that we're seeing a lot of that's really important to consider. What's convenient for the doctor that then breaks the back end for administration. Again, what you can do may not necessarily be something you should do. And we're seeing a lot of need for maybe some help with IT communication with executives. We actually do some presentations called IT to the Boardroom, where we're helping the IT teams to communicate better with the board of directors and the doctors as to why, yes, we understand you're the doctor, and yes, we understand you're the board of directors, but that doesn't mean what you want to do is the right thing to do. Implementations of these types of things really do need to be less of a top-down dialogue and more of a cross-horizontal dialogue about what is the impact. When you go to do this kind of an implementation, as IT, I think you need to come to them and not say no is the first thing. No, because I think that's the instantaneous. I have, as a security guy, I have that response a lot. No. Rather than saying no, maybe you should say, well, let's see if we can find a way to make that work, but here are my concerns as they sit right now. And then find out what it is that they're really trying to achieve with that device and see maybe if there's a more secure or better way to do it. Because we're seeing so many doctors just doing whatever they want and really causing significant holes in the HIPAA compliance practice that in the organizations that we're seeing. Even things as simple as putting passwords on a phone and refusing to do it because it's inconvenient, So when you're implementing mobile health, you have to make sure you put policies and procedures. How many of you have formal policies and procedures that are written? Okay. how many of you are familiar with the Massachusetts Ear and Eye Institute fine that happened about 90 days ago? All right. I'm going to take an opportunity just to kind of give you an idea when you go back, and you're all in healthcare organizations, so this is really important. Massachusetts Ear and Eye Institute is a small not-for-profit. They had a single laptop that was lost by an executive while he was traveling. Massachusetts Ear and Eye Infirmary, excuse me. Single laptop, 3,500 records, $1.5 million fine. The organization was so small that the Office of Civil Rights gave the organization 3 years to pay the fine because it would have bankrupted them. The reason that they got the fine, they did not have a full risk assessment entity-wide. They did not have fully implemented policies and procedures that were written and documented, and they were not instituting encryption across their enterprise. Those are the 3 reasons that were documented. So if you do not have fully documented policies and procedures and full encryption and have not done a risk assessment, when you have a breach, not if, when you have a breach, you too could be on the other end of that fine. And they got hit with what's called willful neglect under the new HITECH Act for health information for economic and clinical health technology. So the bottom line is that HITECH, and you're all familiar with HITECH, right? That's what the requirements did. It extended HIPAA with new fines. That's what HITECH did. It also extended to your business associates. They have the same obligations that you do now. If you don't have signed contracts with them, you're also in violation. As you start to do these mobile health implementations, you also have to consider the implications of who you're connecting to. Those are going to be often business associates. So when you're doing your implementations, you have to have your standards and procedures, you have to do your risk assessments, and you have to make sure your data is encrypted. Those are 3 points. That's why I'm making this point. HIPAA is deeply ingrained in mobile health. And in fact, I would say nothing more is going to be impacted by HIPAA than mobile health technology. Nothing is going to be more impacted. It's really important that as you start to think about this and you have people pushing you to go mobile, you need to be thinking about it.
Good point. And I think that's a pattern that we see fairly on a fairly regular basis, that the technology always gets ahead of the processes, the workflow, the regulation, and so forth. And then,
a question.
Yep.
Sure. Are you working with small, medium companies or larger companies?
Well, part of
Okay. Sure. Sure. With my experience, the ROI has the meaningful use incentive has really helped with that. Their ROI is almost, they're getting all that money back implementing these technologies, at least electronic health records. Now, sometimes if that's not an option for them or you need a different point, just the work, some of the things that you may catch by implementing this new technology, or if you go through their whole workflow process and maybe identify some points that they're not aware of. For example, we worked with a small provider. He thought everything was running okay. He didn't really want to go with anything. We did a full workflow assessment and found out that the accounts receivable team was not following up on any overdue bills. And for the last 5 to 6 years was just writing off every overdue bill as an expense. So he was receiving his check, and he thought everything was going okay, but these little problems inside the workflow that were caught that he didn't know about. So now the ROI, is definitely, he's going to see that immediately because those billables are now going to come in because they have an application that can automate that process. Your app may be special to a certain process, and maybe you just have to do a workflow analysis of that process and see where you can help them.
And the problem is the only real way to gauge is to use surveys, and we've found that market surveys, they tend to go, yeah, that would be awesome, and then you deploy it and they don't use it. So it really is hard to say. I mean, as market people, we can tell you it's a hit or miss. Although internally you may have a little bit better accuracy because people tend to be held accountable for when they say in the survey, yeah, I would use it, and then they don't. It's a little different than if I go to a customer and say, if I built this, would you buy it? And then they don't buy it, what can I do? I can't really hold them accountable for it. But doing internal surveys and asking people what functionality would help you do your job does help. If you can show your management that people say, yeah, that would be fantastic, and here are why, here's the 3 reasons why I would use it, is helpful. One thing that's important too, how many of you have done EHR and are getting incentives from ARRA? Anybody? Okay, because if you do MU15 attestation under the ARRA stimulus money, they can take the money back if they find out that you attested to being MU15 compliant and you're not. So, and they will also audit you for your security compliance once you attest to MU15. They may not take the money back, but they're going to take it back through fines, is my point. They're not going to actually go, give me back the stimulus money. They're going to say, oh, that audit just found that you were non-compliant, so they'll take it back by fining you for your non-compliance and security. Go ahead. Yep. Well, your point is valid about 80% until a lawyer disagrees with you and decides to sue you and prove otherwise. Do you see what I mean? So, yes, I agree with you. The only problem is that, first of all, in the state of California, HIPAA is not really relevant, meaning it's relevant, but California has more stringent requirements than HIPAA does anyway. So the way the law works is if the state law is more stringent than the federal law, it overrides the federal law. So California says you have to protect the patient's rights regardless. If you are allowing the patient to access that data through that application and you're not putting a disclaimer as they enter that says any accessing of this data using an external application is at your own risk, blah, blah, blah. There's an argument that an attorney could make that says you allowed him to do that and therefore you assume liability. I'm just thinking the way troll lawyers think, right? So I agree with you that as soon as and this is why I said the consumer applications I'm less concerned about. It's when you begin to integrate those consumer apps into your environment is when this starts to become a problem. The second a consumer app becomes a institutionalized app, now we have a big problem because now you have a consumer that's controlling the access to that data, and all of a sudden now you have mixed liability because you have an end user responsible for the complexity of their password and who they allow access to it and so on. And whose fault was it that record got breached, right? Was it theirs or yours? So I agree with you fundamentally. But again, like in California, they'll sue you for being ugly, so it's hard to say what would happen in the long run.
Can I see another hand out there? Okay. Well, let's jump back for a moment to workflow. because if there's not alignment of technology and workflow, inevitably there's going to be problems. So Jeff, when you are either starting a new engagement or with your existing customers, when is that introduced into the conversation, and what typically follows from there?
Sure. So the workflow is really everything in the office. So it's immediately introduced, and we acknowledge that the workflow is the primary thing that we may be helping them with, whether it's using technology or software or combination. We're really modifying their workflow. So the way that we handle it is we identify some key employees that have been there for a long time or know the system and how that office works, and we document their existing workflow, and we find out what they're really trying to accomplish on all these steps, and we see where we can improve their workflow by implementing technology or using different software packages. So the workflow is definitely the most critical part of the process. We have to identify their goals and how we can help achieve their goals more efficiently.
I think that's the interesting thing, too, about when you're doing these implementations. In order to do a proper implementation, you have to do a risk assessment. And in doing a risk assessment, you're doing workflow analysis. And the efficiency gains that you get, or efficiency understanding that you get out of doing this type of work is pretty phenomenal. So I tell everybody, instead of being averse to doing these assessments, I think you would be really amazed at what insight you gain into the types of ridiculous redundancy and system failures that you have in the way you operate when you do a full assessment of your organization, and how many efficiencies you can gain by doing a full assessment of an entity in the way that you work. And these workflow assessments and security in particular, as you do workflows for an EHR and for the risk assessment of that, you have to assess every type of operation. And you just go, gosh, I can't believe I did it that way. I'm touching that document 8 times instead of twice, or whatever it might be. It's really surprising how much you can gain from doing these type of assessments as part of an implementation.
Yeah, like we mentioned before, the worst thing to do is throw out a piece of cool software or cool technology and work backwards.
Yeah.
Say, this is what I want to use. I want to use an iPad or an iPhone only, and then create all these workarounds and create a really loose foundation for your whole company. You really have to document, put it down on paper, and then see what technology fits into that workflow.
Yeah, it's the difference between building a house on concrete and sand. I mean, if you take an unfoundational app and you build something around it, you start building layers on it, and later on you find out that that app isn't either appropriately secure or doesn't have the depth of use or depth of capability, and you have to peel back all those layers. I mean, what's that going to take to do? So it's much more appropriate and efficient to do your front-end work prior to implementing.
Yeah, and we certainly will begin to see more and more mobile device management software, both options but also greater adoption. And there's a couple of companies on the show floor that were exhibiting some of their MDM, but so far the utilization is still pretty low, and not just in the healthcare space, but we find this in research across many, many sectors, that it's still something that a lot of IT departments and CIOs are still wrestling with. And certainly once you introduce multiple operating systems, multiple devices, and whatnot, there are quite a few variables to consider. Is that something, though, you're seeing customers either bring to you, or is that something that you can envision greater implementation of some type of MDM solution?
Yeah, the MDM is inevitable. Everyone wants to go with a tablet or a smartphone. They want to work remotely, and you have to be able to manage it. It's required that you manage it. So you need an MDM solution that can remotely wipe these devices if they're lost, set up Wi-Fi networks. Right now the MDM software is limited on both the Android and iPhone platform. It's not fully functional from what I found, but that'll come, and it will come quickly. And once you can really control that device like you can control a computer, I can see that really being utilized more than it is right now.
Setting up implementation plans and make sure that end users are educated on their mobile device use is really important too. I went into an environment recently where they had done encryption on their laptops, for example. This is a really good example of policies and procedures. They had done the work to do the encryption, but they had trained the employees to put the encrypted devices into sleep mode. Sleep mode doesn't encrypt the device. You have to turn the device off in order for it to be encrypted. So effectively what they had done was encrypt the device and then teach all the employees not to use the encryption function. So it is important that when you do these things, that one, you understand the technology you're using, and two, that you make sure that the users are, doing the effective thing at the end. So now the training, of course, has changed, and they are instructed to turn the computer off, not just close the lid or hit sleep mode. When they turn it off, they're actually told to shut the computer down so that they have to reboot it when they restart it. So not all of the encryption technologies are that way. This particular software was one that required that. So it's just important that you don't do things halfway. It is important that when you do your work that you think about what you're doing and that the end users are a part of your plan. That you don't just hand it off and go, okay, I did my work and good luck. That there's some thought in the implementation.
Yeah, I think the training that cannot be stated enough. That if it's either omitted from the implementation or it's a one-off, there will be problems. And we see this both in the research, and I'm sure you both can share experiences where there's a single training session and then that's it. And of course, everyone forgets it, and 6 months later, they either fall into bad habits again or they fail, because it just, like anything, there's a learning curve and it takes some time to digest it. Maybe they're using the very basic features, but then when they get to some of the more advanced features, they forget what the training said. And it's interesting because there are certainly some new training options out there, and e-learning is something that we see more and more industries are turning to because it is a little bit greater flexibility. There's better ways to add in a testing component, so it's not just someone who is asleep in a training session, but they're actually quizzed on it, and it can really help to drive some of that. But is that part of your engagements at all? Is there a training component, or how does that fit in?
Yeah, sure. So what I like to do with the small and medium-sized practices, let's say there's 50 employees or less across a couple offices, is find that one person in the office that is like the go-to IT person when a real IT person isn't there. And I make sure that that person knows exactly what they're doing, and I can communicate with that person very quickly. So I know when an employee is having problems and they go to Sally and ask her, how do I encrypt this email, that she knows what she's talking about if it's just going to be a quick question. And it's important to have that person that you can rely on in the office, because they may not call you for every single issue. And it's nice to have that one person that you can rely on. But also always let them know that you're available if they have a question, that they should contact you, and they shouldn't just do something the wrong way, because it may be more detrimental than just that quick phone call. But we'll do formal training with small groups, and then we'll also just create quick documents on how to do things. It doesn't have to be very long-winded. It could just be a 5-step process for whatever workflow we're working on. So training is definitely important, and having that one person you can rely on is even more important.
Once again, it's also part of the HIPAA regulations. For any of you that are new to the regulations and you want to get a quick education on what an audit looks like, if you go to the HHS website, you can do a Google search on the HHS audit protocol, and it will actually show you exactly what you will experience when OCR shows up at the front door. They've done a pretty comprehensive job of explaining what an audit looks like. It used to be pretty ambiguous as to what you can expect. Now they're giving really good cross-referencing information on what to expect. And there have been enough of them now that have been public. You also can see what are called resolution agreements, which is very interesting. They share the reports for those organizations that have been audited and have been fined for why. So they tell you exactly what happened, what the condition was that the fine was related to, and then what the agreement was that caused the solution, and then they tell you how they're going to get out of it. One of the examples that's really scary was the CVS one. It's a large entity, but CVS Pharmacy, this is several years, I think it was 2009, as I recall, but it's still a pretty big one. They were throwing away medicine bottles, and they got hit with a multi-million-dollar fine and 25 years of auditing by the FTC. So that's not one I would want to participate in.
Since we're on the topic of compliance, and Kevin, even though this is a little bit outside of, I think, the mHealth discussion, I still find it fascinating. Maybe you could just share some of the social engineering penetration tests that you run, and a few of the examples that you can share that I think would open some eyes just regarding the risk not only on premise, but certainly you can envision some of these risks in a mobile environment with various mobile devices.
You know, that's actually a good point, and I'm glad you raised it because I thought to mention this. Texting is going to be ubiquitous, and I've seen several texting apps. And there's a gentleman, and his name escapes me, there's a gentleman in the last week who's released a document that states he can spoof texting and proved it through Twitter, and just released an announcement that he can spoof texts and spoof tweets based on counts, and can now tweet on your behalf, as an example, using texting. So one of the risks, of course, is if you're using texting back and forth and someone knows your cell phone number and can spoof your doctor and send you the wrong information if they choose to, this could be a risk. So an example of social engineering that I do is I get hired by organizations, and I work with larger enterprises, anywhere from 50 seats, 10 doctors and 50 employees and up, to my largest clients, about 12,000 employees. And I'll do social engineering where I'm handed a letter by the CEO or the chief financial officer or whomever I'm contracted by, and I will do my very best to find my way into facilities I'm not supposed to be in. And so far I have a 100% success rate, which is kind of sad when you really think about it. It either says I'm kind of creepy or these organizations are not very good at securing their facilities. Now, I have a 100% success rate on first try, but once the organizations are trained in the facilities that they don't know me, I have a 100% success rate at failure afterwards. So this tells you that once organizations are trained. So I'll give you an example of what I've been able to do simply by grabbing a clipboard, putting on a suit, and a little bit of an attitude. I've been able to get into data centers, surgery centers, clinical areas where medications are distributed, medical records rooms. I actually walked into the middle of an operation and said hello and waved to the doctors as they were operating on somebody, and said, "Oh, I'm sorry, I'm looking for the IT closet," and they said it's 2 doors down. They actually looked up from the surgery. Now, it was minor in what do we call it, outpatient surgery, but the man was operating on somebody. But the point is, part of doing security, and this goes to the mobile health, part of considering implementations is what would be a way to socially engineer bad things from that device. And is that device going to be capable of influencing clinical decision making? And if it is, what is part of the risk of that process? So one of the things you have to think about when you're putting these devices in place is what would someone with what I like to say a fiction mind, I'm actually a writer, so I like to use the fiction thought process. If I was writing a screenplay of something really bad, what would I do? And then I use those type of thought processes. So try to think a little bit out of the box when you're doing your risk assessments. Another thing I did was we found an ID hanging in someone's windshield. We took a photograph of it with a telephoto lens, put it in Photoshop, and made a copy of the ID. It's very simple to do. Put my photograph in it, and voila, I was part of the security team. So these are things that if you really think just a little bit out of the box, it's not very hard to do. So when you're setting up your security protocols and your policies and procedures, be considering things like that idea. If an emblazoned logo from the company behind the photograph, I wouldn't have been able to do that because I didn't have the logo hanging on the wall that I could stand there and take my picture with, right? In this case, the logo, I just took it off the website as a copy, and I had a clean copy logo because they had their exact copy of their logo up on their website. Don't ever use your high-resolution JPEG as part of your website. Simple things like that. So anyway, these are some examples. The other example was I walked in and pretended to be doing an inventory of IT, and I simply asked the person where the IT closet was, and she said, "What's that?" And I said, "Your computers." And she said, "Oh, there's one over there." I said, "No, the big ones." And she goes, "Oh, they're back here," and walked me right back and dropped me off in the data center. So training people not to allow that to happen is one thing. Part of this discussion has to do with the doctors. Making sure that it's okay to question doctors. Doctors have a tendency to not be too nice, and I don't, if there's any doctors left in the room, I don't mean to be offensive, but many of the employees told me that it was their fear of the doctors that allowed me to get into several of these facilities. They were afraid to question the doctors. So these employees have now been trained it's okay to question anybody that looks like they don't belong where they are. So that's one of the reasons we raise this. We have to train people in today's world that it's okay to question people when they're in places that they may or may not supposed to be.
Yeah, certainly this is another example of no technology operates in isolation. And while this is an mHealth summit, we are not talking about mobility outside of the greater technology ecosystem. And another example that comes to mind is disaster recovery and business continuity. And there were quite a few examples that were highlighted recently with Hurricane Sandy. And I think that's another area that sometimes is probably overlooked in some of the smaller practices. Jeff, is your firm doing anything along those lines?
Well, the one firm I work with, their digital phone provider was based out of New York. And they were hit by Hurricane Sandy, and they didn't have their phone system for over a week. Luckily, they did have a backup plan, and they had 2 standard phone lines that they were able to use to make patient calls and everything. But most of our providers are in New Jersey, so they were so backed up from people taking off, patients calling in, canceling. For the next 2 to 3 weeks, they were seeing almost double the amount of patients they normally would in a given day. And having the technology there and everybody trained is just another point that it can be more efficient than the standard paper system. And having everybody trained on these protocols definitely helps in a disaster type situation.
Is there a disaster recovery component of HIPAA or HITECH?
There is. You not only have to have an emergency modes of operation plan, which allows you to operate during a disaster, but you have to have a recovery plan that brings back the record. So HIPAA covers 3 factors. It covers the privacy of the record, the integrity and the accuracy of the record, and the availability of the record. So your responsibility are to those 3 things. It isn't just protecting the privacy and security of the record. You have to make sure that it's available when the patient needs it and the doctor needs to treat them, and when the patient requests a copy of it, and you have to have it available, and it has to be accurate, and then it has to be protected from breach and disclosure or improper disclosure. So yes, there's absolutely a component of disaster recovery.
Any questions on any topic?
You're actually in more trouble now for not doing it at all, because that is direct willful neglect. Depending on well, let me disclaim that. If you do a risk assessment and there's too large of a gap between the risk assessment and your remediation, you're in trouble. because now you've tested and haven't taken an action. If you do no risk assessment at all, you are blatantly willful neglectful because the regulation was from 1996, and your compliance, all compliance dates passed back in 2003, 2006 was the latest date. So the OCR says there's no excuse unless you just purchased the organization in the last 6 months. There's no excuse for not being compliant, period. Right. Right. Well, they've done some rulings on that that's not quite true. So if you are using any type of electronic function, which would include Medicare reimbursement verification via the internet, then you are a HIPAA-compliant organization. So the bottom line is, I don't think there's any physician's office in the country that really isn't a covered entity. I mean, I've yet to find one that if you looked at the way they operate, that they're not using some sort of electronic functionality at this point. Under the privacy rule, now the security rule, there's two separate halves of HIPAA. There's the privacy rule, which covers all forms of medical information, and then there's the security rule, which only covers electronic records. So it's two different halves. If you do not have an EHR system or electronic records, which would include PDF copies, digital copies of records, then yes, the security rule does not apply to you. But the privacy rule set does apply to you if you're doing any functions whatsoever. Anybody else? Go ahead. Yep. Wow. That's a really good question. You want my straight answer? The answer is yes, you can't do it because are they going to be getting any of your data? Or are they going to be only getting research data or de-identified data? So then, no, you can't. You have to, if you're doing anything that involves them possessing, sharing, looking at, in any manner, they have to sign it. And in fact, it's illegal for them to refuse to do that. So that's interesting that they're saying that because that's actually illegal. The obligation under high tech doesn't extend from you, it extends from them. So if they accept, this is an interesting point, and I would argue from your attorney's side, you may want to have your attorney look at it, but if they accept the pilot, the obligation is not from you to ask them for a business associate. Their obligation is for them to give you one. It's not the other way around anymore. So technically, their refusal to accept your request for one is actually illegal. So I would argue that they can't do that. I would start the pilot and then call OCR and say, "Hey guys, these guys won't sign a business associate agreement with you." So. It's still a statute requirement. So even if you encrypted the data, that means you're reading line 1 of the statute. You're still ignoring line 2 of the statute. So I wouldn't do it. Yeah. Business associates, and by the way, business associates are now obligated to meet all of the same regulatory requirements that a covered entity. They are literally the equivalent of a covered entity. They have same policies, procedures, same disaster recoveries, everything. They have all the same requirements.
Anyone else? All right, we have just a few minutes left. Jeff, Kevin, any closing thoughts or anything you want to recap before we
Yeah, I'd like
end
to make
things up?
one just really quick comment. I seem like a naysayer to this stuff, and I'm really not. I just want everybody to understand that with all of this really cool innovation and really great, neat stuff, I know a bunch of people that are on the compliance legal side of this thing. They don't care how cool you think it is, and they don't care how much it benefits you and the patients and the doctors. And the lawyers that are on the compliance side of this at OCR are the same attorneys that will sue you out of business in a malpractice lawsuit. They don't care. They're out for patient privacy only. So what I want to suggest is that go for the innovation, go for the really cool stuff. Just really think carefully when you're doing it and make sure that you're considering what you need to consider in doing it. I think really great things are going to happen in mobile health, but I think the regulatory environment needs to catch up so that you don't rely on what's currently out there and then get into trouble later on because they change their mind or their interpretation becomes something different than it has been. That's really what I have to say about it.
And I would say, in the small to medium physician market, if you are a physician, you should definitely go out and look for a consultant that can help you in this process. And if you're a consultant or a service provider, you should start by looking at your own internal company. Make sure that you have these processes and your internal processes that could actually support these companies. And then start by documenting the workflows, working with key employees and training everyone, and then finding the technology that fits within that workflow, whether it's mobile health or standard technology. Don't go the other way. Don't look at the technology and then modify the workflow.
And then last thing, whatever you do, encrypt, 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 encrypt. 10 times encrypt. That's all I can say. Encrypt. That's okay. Yeah, to your point, I'll reinforce what you said on a couple of things. One, start with HIPAA because HIPAA's the floor. So a lot of people say, oh, HIPAA's the greatest panacea. I'd love to be able to comply with that. It's like the perfect. No. HIPAA's the minimum requirement. If the state provides for better or more strict protection, then you must follow the state requirement. Several states actually provide for more protection. California, Massachusetts, a couple of really good examples. Very strict requirements. Penalties are more severe. Mental health, drug addiction, sexually transmitted disease, very severe, stronger protections than just your normal medical records, for example. That's a good example. So yes, you do need to consider all of that when you're dealing with any of these type of issues. You also have the difference between an institutionally provided product or service and a consumer-oriented, self-induced or self-chosen device. And I still think what we're going to end up with is something's going to happen very quickly where we start to see, okay, 10 million people are now using these. Guess what? These regulations are now going to extend to those people as well. I don't believe we're going to see very long where there's going to be some miraculous exception somehow where people can be stupid. I hate to use the term, but because the consumer doesn't understand that this isn't covered under HIPAA, that they can release their cancer records and their HIV records and it's no big deal, right? Currently, that's the way it is because it's not regulated. So I think that will change as well. So that's why I caution everybody, hang out for the next 24 months because the Obama administration is very serious about privacy, and I don't think we're kidding ourselves if we think they're not going to hit us really hard with regulation. Very valid points.
All right, a lot to think about and a lot of information at this event. So thank you very much for joining us today, and have a good afternoon. Thank you.